Welcome to Main Street Media, Utah. My name is Laurie Gagan, and I'll be your host for today's show. And I'm one of four Wellness Crusaders, and we are the Wellness Crusaders talk radio show. But before we get started with our guest speaker tonight, a little bit about the Wellness Crusaders mission. The Wellness Crusaders internet radio show weaves together the critical and often overlooked aspects of wellness, including the crucial role of soil health. This engaging series unveils a crucial truth. The health of our soil is deeply intertwined with nutrition, climate, and the sustenance of all life on Earth. For years, rampant use of chemical farming methods has drastically depleted essential soil nutrients, leading to a decline in plant health and our overall well-being. These podcasts emphasize that nutrient-rich, high-quality food is the foundation of our mental, physical, emotional, and spiritual health. We address the critical issues of our diets being deficient in essential nutrients, a problem increasingly linked to rising mental and physical health challenges. The Wellness Crusaders not only highlight these issues, but also provide answers and solutions. Upholding the wisdom of Hippocrates, let food be thy medicine and medicine be thy food. We are committed to empowering lives, inspiring wellness, and offering solutions. And we hope you will join our crusade. A few disclaimers before we get started, and before again I introduce Dr. Richard Fleming into the show, that the listeners understand that the role of the health coach is not to prescribe or assess micro and macronutrient levels, to provide healthcare, medical, or nutrition therapy services, or to diagnose, treat, or cure any disease, condition, or other physical or mental ailments of the human body. Rather, the coach is a mentor and a guide who has been trained in holistic health coaching to help clients positive, sustainable lifestyle changes. The listener understands that we are not acting in the capacity of a doctor, a licensed dietitian, a licensed nutritionist, a psychologist, or any other licensed or registered professional, and that any advice given by the coach is not meant to take the place or advice of these professionals. The listener is under care of a healthcare professional or currently uses prescription medicines. The client, the listener, should discuss any dietary changes or potential dietary supplement use with his or her doctor and should not discontinue any prescription medications ever without first consulting his or her doctor. The listener understands that the information mentioned in our talks should not be seen as medical or nursing advice and is not meant to take the place of seeing licensed health professionals. So, once again, welcome to Main Street Media, Utah. I'm joined today by Dr. Richard Fleming, lead contributor of 10letters.org, which we'll be talking about later on our show. He is the author of COVID-19, he is the author, Is COVID-19 a Bioweapon? Which I have to tell you is a must-have book for everyone wanting to understand how and where this deadly disease known as COVID-19 got its start. He is also the author of Stop Inflammation Now, which back in 1994, he spoke at the American Heart Association, where he introduced his theory on inflammothrombotic response, what we know as inflammation. His theory became part of the cardiology textbook in 1999. His research into SARS-CoV-2 began back in January 2020, but his research into gain of function led him back to around 1999, when the U.S. Department of Health began funding research looking at infectious diseases. My husband and I initially met Dr. Fleming at an event called Crimes Against Humanity Tour in October of 2021, shortly after my brother, who got COVID, was murdered at a hospital in Idaho by not being able to receive the correct medication to stop the spread of the disease. Dr. Fleming has spent years, decades, graciously giving his own time in order to educate the world on the knowledge that he has about inflammothrombotic heart disease, as well as COVID. So, Dr. Fleming, I'm honored once again to be speaking with you live on mainstreetmediautah.com. So welcome. So
Thank
today
you.
I would like to cover the virus. I often refer to it as the toxin, SARS-CoV-2, in heart disease and neurological disease, as well as inflammothrombotic disease, which is what we know as inflammation, the fire in your body that promotes illness. So let's start off with the first question. Can you tell our listeners what led you down the path of wanting to understand where and how SARS-CoV-2 got started? And I think there are many people who understand the relative cause to the systemic responses of the disease based on a target receptor we know as ACE2, which is talked about quite often now. But what led you down your path?
Well, quite simply, anytime a research physician like myself sees something coming up new that needs to be addressed, very similar to when I was a medical student and HIV came along, the questions are raised. What are we dealing with? What types of problems should we expect? And how can we address it best for the benefit of the patient? When you do that, you have to start looking at what information we know, all the work from people before you. And that was really the first steps for me. In January of 2020, I began the process of trying to put pieces together, including taking the theory that I'd worked on and developed over the course of many, many years, and then asking, what do we know fundamentally about viruses? This is clearly a virus that we're talking about. What types of treatments have been beneficial? Whether people are aware of it or not, there was a lot of research that was published on a variety of viruses, and that allowed me to pick out some different treatment options for people. There was information about more fundamental needs, about nutrition and diet and lifestyle and vitamins and minerals, and how those could help the immune system. And then we needed a way to actually measure the outcome. And most tests, are do an adequate job under general circumstances, but to really measure subtle changes, you need something that can look at the tissue. And there's a couple ways to do that. You could either give people treatments and do biopsies of them, or you could do the method that I've patented, FMTVDM, or Fleming method, as people like to call it, where you can measure tissue changes. And so with that, I set out to do research, and we did that in multiple countries. But while doing that, it's also important to have a better grasp of what exactly are we dealing with. And when you do that, at least for me, when I did that, with the assistance of a lot of people trying to say, here's something I found, here's something else we found, please take a look at that. That process led to an unraveling of papers and scenarios and patents that were very, very useful for actually trying to understand where this virus or viruses actually came from, how it got put together, which was critical because it gave us some answers about treatment options. And so all of that put together, it's multiple things happening at the same time, which is true of science and medicine for any problem you're dealing with. And we just simply put those pieces together and followed where the information took us.
Okay. And how many versions of the virus are we up to now? I know it started off as a alpha, but I know we're still on Omicron. Where are we? How many?
Right. So I think we're on the 17th or 18th version of Omicron, and I think total there's something like 40 variants that exist that have been mapped out to show how they relate to each other, what they share in common with other variants, what's really different. The current one is the one that has probably the greatest number of mutational changes. So independent upon whether a virus is man-made or naturally occurring, or the same thing's true of anything else, bacteria or fungi, you name it. Once it exists, there's going to be changes that occur, just like there's changes in human beings. I don't think people need to look too far to see the difference between you and I. You have black hair, I have this time gray hair, but it used to be blonde. You have darker eyes, I have blue eyes. All of that are the human variances that exist, and they continue on from day one. And so, independent of what causes something to come into creation, there are variances that will continue to occur, and they will continue to occur for these viruses.
Okay. How come we haven't moved on from Omicron yet? Like how?
Well, that's a good question. I mean, there's multiple ways of naming these. Using parts of the Greek alphabet is one method. There's other methods that use English letters and numbers. I do think it's interesting. It's Omicron. I think I mentioned to somebody the other day that I guess they'd kind of given up on trying to educate people on the Greek alphabet. They'd gotten to Omicron, and that was good enough. But I think Omicron is one of these variants that when we saw the Omicron variants occurring, we saw a real significant change in the mutations. And it's kind of that branch, it's kind of like, why does everybody who's a male in my bloodline get called Fleming, even though we may be changing over the course of time? And this is kind of the branch that we're on, which is the Omicron branch. And so as long as that is the dominant variant, it's going to be an Omicron strain.
Do you think that possibly they're not moving on because there could possibly make creating a more harmful version and they'll move on to a different name?
Well, so as far as the virus is concerned, usually what viruses do, again, independent upon whether it's man-made or naturally occurring, is they find their niche, their area where they are very good at infecting, but they don't really want to kill the host, because if it's a virus and it kills its host, you and I in this instance, it can't escape to, live another day. It's going to die. And so there's a benefit to it kind of settling into a place where it can maximize its infectivity and maximize its pathogenicity, its harm, without actually outright killing the host. And I think that's what Omicron has really kind of settled into.
Okay. Okay. So the next question. So the concentration of these receptors, they're found I know they're found in a lot of organs in the body, but they're found in the heart and the lungs, in the gut, in the liver, the reproductive organs, and the vasculature. And we are seeing a huge rise in cardiovascular problems and inflammation, even in the younger generation. Can you talk a little bit more about this, please? And please keep in mind, there's only a few nuclear cardiologists in the country, let alone the world. So it's super important to me that our listeners can comprehend what you're talking about in order for them to educate others.
Sure. Most everything in the human body, or any other living organism, sits in a balance, what we refer to as homeostasis. So if you activate something one direction, you get one response, but it wants to stay in balance, which will give you the opposite response. ACE2 receptors, or angiotensin 2 receptors, There's several types of them. There's three major types. The major one that we see, which is known as number one, actually causes blood vessels to shrink down, blood pressure to go up. That's an important receptor to have in your body. If you think about it, when people pass out, it tends to be because their blood pressure gets too low. It's one of the major reasons. So this ability to narrow blood vessels and increase the blood pressure tends to keep you upright, and it has a benefit. It allows you to push blood through tissue, or what we call perfuse it. And the balance trade-off on that is that if you go the opposite direction, there's something known as the bradykinin system, which slows down everything in the opposite direction, causes the blood vessels to relax, causes blood pressure to drop. So this balance here that people are working with, it turns out that when the ACE2 receptor is activated, it tends to cause the driving up of the blood pressure, vasoconstriction. One of the consequences of that is an increase in blood clotting tendency. One of the consequences of that is an activation of this inflammation part of the sequence. And so you hear me talk about inflammothrombotic because you can't have inflammation without blood clotting. You can't have blood clotting without inflammation. It's a lot like the term electromagnetism. You can't have electricity without magnetic field, or magnetic fields without electricity. So they're connected. And when this virus, the spike protein, activates those ACE2 receptors, it will do anywhere in the body where those receptors are found, and they're found in every blood vessel to maintain that blood pressure, either increase it or lower it. So every tissue in your body has these ACE receptors. So it's impossible to get away from it. It's necessary, it's critical, it's vital for humans to survive. And yet, one of the ways in which this virus is brought into contact with these ACE2 receptors is through a part of something called Nrf5AC, which is just a sialic acid receptor. So you can think of it like aspirin if you want to. That's a sialic acid, and it's a receptor, it's a RAF. And part of the spike protein, the part that has part of the HIV part to it, connects up there, and that's what allows it to swing into the ACE2 receptor. And it does it quite eloquently, and it activates it, causing this inflammation and blood clotting.
Are there any other viruses that have made their way to and through the ACE2 receptor?
So the only ones that I know of that do that consistently are the SARS-CoV-2 viruses. And so SARS means severe, really bad, acute, really sudden, respiratory, your lungs, syndrome. You have breathing problems. And then coronaviruses. And there's about 7 well-known ones. MERS was one, the Middle Eastern respiratory syndrome. The first one was SARS-CoV-1, which was almost 2 decades ago now, or a little bit more than 2 decades ago now. They're the ones most actively known for it, but there's unique things about this virus in its spike protein that you don't see in other SARS viruses. And one of those is this classic furin, F-U-R-I-N, cleavage site. It's a set of 4 amino acids that sit there that is unique because it allows, once this spike protein gets to the ACE2 receptor, to split that spike protein apart and bring the virus inside the cell. And so it's actually very critical to the ability of these viruses to have the effect that they do.
Okay. In your book, Is COVID-19 a Bioweapon? It's actually a really excellent book, and it's a good read. And for most of it, it's an easy read for people to understand. I mean, I like how you laid out the patents. And I honestly think for anybody looking at how the heck did this happen? Where did it get started? I think it's such a great book to have. But so SARS-CoV-2, you mentioned a couple of viruses, but it goes back to what, the early 1990s?
Well, yeah, this a lot of the very fundamental gain of function research, this mutational change manipulation by human beings for these viruses goes back to 1990s. There is some research that dates back before that, obviously, that wasn't included in the book because it wasn't about these viruses. But there is some gain of function work that was done before them. That is significant because it shows a paper trail of how these researchers did this work. There was a transferable gastroenteritis virus that Ralph Baric at the University of North Carolina was working on very heavily before the coronaviruses. And it was actually it looked like one of his favorite ones. It was one he kept doing work on. And that provided the natural pathway for him to find these coronaviruses and to begin experimenting on them.
Okay. Which resulted in millions of people dying, including my brother.
Yeah, this, independent upon whether you look at just the infection going into people and causing a pneumonia, or when you take into account the fact that this virus sets off this inflammothrombotic response, causing heart attacks, strokes, kidney failure, liver failure, abortions, sudden cardiac death, and cancers. When you realize that that's kind of that last precipitating factor, then you have to look at, I think it's a valid argument, that you have to look at all those deaths as being due to this gain of function biological viral weapon getting released and having the consequences. So if you have a lot of, it's that old what straw that broke the camel's back routine. And if you don't treat that, if you don't address the problem when it comes in, it's very challenging to have a good outcome. And we saw in the United States more deaths than we've lost military men and women since 1776. We've seen more injuries since we've had injuries in the military since 1776. And that was all done in about a 3-year period of time. So I think that speaks to just how dangerous and harmful this has been just in the United States.
Right.
Not to mention the rest of the world.
Sadly, no, you're right. So you and I did a podcast with Dr. Kevin McCurran, who is totally amazing as well. We talked about neurotoxicity in the brain. What I'm seeing coming up more and more are medical articles talking about things like sundowner syndrome, even the growing number of dementia-related diseases, as well as brain inflammatory diseases related to SARS-CoV-2, the spike protein, the COVID shot, and inflammation. So can you talk a little bit more about this, please?
Right. Well, there's a couple of things, as you mentioned, that really are going on here that is unique. First off, we have a virus that, independent upon whether you've got the entire virus with it attached to the spike protein, or you're just making the spike protein itself, it's causing this inflammation and blood clotting, inflammothrombotic response. On top of that, we have an additional complicating factor, which is that the spike protein itself has areas that are referred to as priogenic. They cause prion disease. And so prion diseases are problems that occur when proteins get malfolded so that they don't work and they start to interfere with the function of wherever they're at. So in the heart, when that happens, you can have something known as amyloidosis, and you can have sudden cardiac death and heart failure as a result. In the pancreas, this has been shown to be associated with an increase in diabetes in the patients where this is happening. And in the brain, it is producing these neurologic diseases. One classic prion disease is known as mad cow disease. Other diseases that are associated with these prions are diseases like Alzheimer's diseases and a variety of other neurologic damage. So we know that the spike protein of these SARS viruses very easily crosses the protective area around the brain known as the blood-brain barrier. It's supposed to protect the brain from having outside things get in. And you can kind of think of it like your skin, if you will. It's a barrier to, if you're on the outside, you stay out. If you're on the inside, you stay in. But this blood-brain barrier is breached by these viruses. It's also breached by the lipid nanoparticles, the soluble fats that these genetic vaccines are encased in. And, it's kind of a double whammy, when you think about it. Neither mechanism protects the brain. They both get through to the brain. They have both been shown to cause prion diseases. They've both been shown to cause inflammothrombotic diseases. So you can have strokes or blood clots, you can have Alzheimer's, you can have neurologic disease, all due to this. So this is an unusual combination of events that's going on with this particular virus and these genetic vaccines that we've not seen before. And we now, the CDC, for all the things that can be said that we're not pleased with, has done a great job of keeping track of records, and they've shown over the last 2.5 to 3 years, roughly 600,000 excess deaths, most of which are related to these priogenic diseases and these inflammothrombotic diseases. And so, it's their numbers. They're keeping track of it. These are excess deaths, which means when you look at how many we normally have, we now have an additional 600,000 in a 2.5 year period of time that are showing up with all these diseases.
So as a follow-up question to that, do they list the ages of the people who have had?
So no, they don't. There are some areas that you can go to get the ages. And it is true that, they tend to be in, middle age or older individuals where these diseases are showing up. But this is pretty consistent with how disease occurs. So, when you look at what's happened with the American diet and lifestyle, we used to see heart disease, for example, showing up in the 60s, because once that inflammation and blood clotting, that inflammothrombotic response that causes heart disease occurs, it takes about 2 decades for it to build up sufficiently to have an effect. And what we have seen, you can go back to the 1960s, but definitely the 70s and 80s, is that the age of onset at which these diseases started to occur were beginning to be younger and younger and younger as we started to see, 1/4 to 1/3 of our children that were in elementary school to high school being overweight, diabetic, having high blood pressure or high cholesterol. So the onset of these diseases have been moved back, and it takes a while for them to occur. So it would be unusual to see a problem show up in younger individuals. Not that it's not happening, but it's not expressing itself. It's not being seen. But if you're older and you already have been working hard on your diet and lifestyle to kill yourself off, and now you throw another factor on top. Well, I used to explain this to people. When you have a fire, you don't put it out by, instead of throwing a gallon of gasoline on it, throwing a pint of gasoline on it. It's still going to burn more. It's just not going to burn as much or as rapidly. So when you already have this fire going on, this inflammothrombotic disease, or you already have these neurologic changes going on, and now you add insult to injury, you should expect that these are the people you're going to see the consequences on, not the people that are relatively healthy, because it's going to take a while for these health problems, these diseases to show up.
And, just the people who are listening out there, it's not just the COVID shot. We're talking about the COVID shot and the spike protein. Is it the spike protein? Is it the COVID shot? Is it a combination of both? So, Dr.
Right.
Fleming, can prion disease, can it be reversed? A majority of us
Um,
have had COVID.
right. So, that's certainly one of the big questions of the day, which is what do you do with that? I would say that probably back when I was a medical student in the early 80s, the response would be no. In fact, I took care of, Creutzfeldt Jakob or Jakob Creutzfeldt, depending upon who's talking about it, mad cow disease patients. I had some of those when I was a student. And in that time, we would say no. But we've learned an awful lot since then. There are, for example, aloxastatin, or I think it's E64D, is a drug that has been experimented on since the mid 1980s, roughly 1985, and it has been shown to reverse damage to the brain caused by a variety of health problems. Um, we know that niacin has an effect or beneficial effect, not only for the virus itself, for the inflammatory thrombotic response, but also for pyogenic diseases. There's benefit for just adding a number of healthy improvements in your diet and lifestyle, and trying to take some of these other medications and supplemental approaches to try to reduce it. There, as it may, hopefully it's as obvious to everybody as it is to me, that in the last 2 years there has been a tremendous surge in the number of drugs that have been talked about for Alzheimer's disease, for pyogenic diseases, which I find extremely fascinating, because it takes a while to be working on this before these drugs start to show up, which indicates to me that somebody thought there was going to be a problem. Can I tell you who? No, I can't. But the reality is, these drugs are now hitting the market, and many of them are in the research setting, but there's a lot of discussion about it. So my argument would be, first off, what's done is done. Um, there's no point in beating yourself up about it, whether you get infected. I mean, you weren't the ones responsible for bioengineering this and releasing it. Um, if you got vaccinated, look, the vast majority of people probably did it because they thought they were doing the right thing. Uh, you don't beat yourself up about that. You recognize that there's been all sorts of things that kind of push that envelope to make that happen. It's like Carrico and Weissman, and their work on the mRNA vaccines, on the pseudouridine. These people got the Nobel Prize for their work. And I would argue they deserve the Nobel Prize for their work, because if you look at what they did, these appear to be, to me, to be very honest scientist researchers. They were looking for a way to stabilize mRNA. And so they changed uridine to pseudouridine. Some minor changes that, you can look it up if you're interested. I've got it posted on things, but I won't bore people with that now. But some simple changes that stabilize the mRNA molecule. And they said, wow, A, we stabilized the molecule. B, they went further. They said, okay, let's look to see whether this works as a vaccine. And when they did that, they said, this doesn't work well as a vaccine. Interferon, which interferes with viruses and is critical for dealing with infections, doesn't really increase when pseudouridine is used. And they went even further and they said, but this will make a heck of a vehicle for doing gene therapy. So they were right there, and they didn't have to say these things, but they made a point of it in their paper, their 2008 paper. um, so if you knew the research, and like I did, and caught it, you knew that these people were working on this, and you knew what the information showed, and you knew the consequences that were going to be laid the foundation of. so I think it's extremely compelling to ask the question. When the people who developed pseudouridine for these mRNA molecules to be used for genetic vaccines tell you in the paper that is used to get them a Nobel Prize, they tell you it's not good for vaccines, why would you make a vaccine from them? Well, here's the problem. When it interferes with interferon, which it does, making it not good for a vaccine, something else known as vascular endothelial growth factor goes up.
Right.
And you've seen this in this slide that I put together to try to explain why sudden cardiac death, why athletes and other people, their hearts stop. It's not due to some of the conjectured ideas that people have proposed. These genetic vaccines decrease the interferon, increase VEGF, and VEGF itself slows down the movement of sodium across the electrical cells of the heart. So that at the same time that the heart is squeezing to pump the blood out, and it needs to have the sodium flow across the cell membranes, it's slowed down by pseudouridine because the pseudouridine decreases interferon, increases VEGF. That means it takes longer for the cells to recover. And if you demand that they activate again, they will go into a bad rhythm that will result in the heart stopping. And so anything now that increases the heart rate puts that person at an increased risk of this bad rhythm and the heart stopping. Well, what types of things will do that? Well, if you get a temperature elevation, you get infected, that'll increase your heart rate, right? Everybody's been infected and notice that their heart rate's faster and their temperature goes up, and that's because of interleukin. If you're running, if you're athletic and you're trying to increase your heart rate, that'll make your heart rate go up. But if you've got this damage to your sodium channel, it can't keep up with that. It's also true that the pryogenic effect on the heart producing the amyloid disease of the heart, which if you're a nuclear cardiologist, you can test for. If you're not a nuclear cardiologist, you have to send it to a nuclear cardiologist to get that test. We saw more of that than we were expecting to see. And when that amyloid, that protein is layered there, it interferes with the function of the electric system and the heart function itself. It gives the appearance of what everybody talks about as an inflamed heart or myocarditis. And yes, that myocarditis, that inflammothrombotic response can occur, and that can interfere with the conduction of the heart. But you start adding all those things together, like I show in that diagram, that figure, hopefully your viewers will be able to see, or you'll post it on the website, and you have the perfect storm for slowing down the recovery time of these cells, meaning you can't have your heart beat as fast, and yet all of these other things trying to say beat faster, and the end result is you end up with these sudden abnormal rhythms of the heart, polymorphic ventricular tachydysrhythmia or torsade de pois or ventricular fibrillation, or even ventricular tachycardia will do it if it goes fast enough, and boom, the person goes down. And that is referred to as sudden cardiac arrest. And it's due to this perfect storm of all of these factors coming in together. And you have to be aware of that. If you're the cardiologist looking at it, you have to know what types of tests to look for to find the problem and then how to treat it. There's a whole host of people that are born with this type of abnormality that we call long QT syndrome. So LQTS is the acronym for it. But they have hearts that don't allow the sodium to come and go as fast. And as a result, they can have this very same phenomenon. They're born with that. This is something that's caused.
Okay,
Hopefully
and
that answered that.
you said it was, the abbreviation was LQTS?
Right. Long QT syndrome, because this area of the electrocardiogram where this sodium is moving in and out is the QT part of it, which happens to be electrically the same thing that's happening at the same time that the pumping chambers of the heart are contracting or squeezing to push blood out. Right?
Okay. Okay, something else on my task list to research. And again, I just turned off my backdrop because I noticed it was flickering in and out. So for those of you
Sure.
that are watching, I did turn it off. So when we're talking about this inflammothrombotic disease,
Mhm.
how does it differ for someone who got the shot versus someone who didn't get the shot? And differ, I guess, in what's happening with heart inflammation right now that we're seeing. Is it worse to get the shot? Is it the same? I know Dr. McCarran was basically saying, I mean, he didn't take the shot. He's very open about that, but he still is long haul.
Right. So the answer to that question really amounts to a couple variables. How much of the offending factor did you get exposed to? So, how much of the virus did you get exposed to? How much of the spike protein from the genetic vaccines did you get exposed to? And how healthy were you at the time? And how rapidly did you respond to it? Those are all factors that, as you can imagine, vary from person to person, which explains why you're not going to look at a set of data and suddenly see some outstanding result that you can say, well, that's it, right? Because there's variables that play here, you know? Um, so the obvious conclusion is the more insult you had, the more likely you're going to have a problem, right? But we all know people that have been in a room long before SARS-CoV-2 slash COVID, if you will, came into existence where you would say, well, I don't know why everybody else got sick. I was there. I didn't get sick, right? You either didn't get exposed to as much of whatever it was, the virus, if it was, or you were in better health, or you got better sleep, you took better care of yourself. Any of a number of factors play a role. And that's why we see these different outcomes. That's why we see a different outcome in a lot of health problems. That's why we see different outcomes in people that may have the same food. They may be eating the exact same food, right? But what's the difference? You know, how much they exercise, what their overall health is, what their, sometimes there are some genetic differences, but by and large, there's not major differences in the genetics of people that account for it. It just comes up as a good excuse or a good blame. Well, it's not me, it was my parents. They gave me bad genes. Yeah, no. Um, so you add these factors in there and you get different outcomes. Uh, and that's why it takes sometimes a long period of time to come up with answers. I mean, the theory that I developed in 94, I've been doing research on diets and exercise and measuring this stuff for the better part of 15 years, and was actively involved in a lot of the research studies that you've read about. I was behind the scenes in some instances, in front of the scenes in others. I joined American Heart in 1976 as the youngest faculty member, that which was, out of left field, as they say. I wasn't expecting to do that. But by the time I'd gotten into the early 90s, I was really bothered by the fact that it wasn't shaking out so easily. I mean, why was cholesterol more of a factor in some people than other people? I mean, the data was very clear it was an issue, but why? And that's where I had to sit down and say, we've got to take a bigger picture look at this. We've got to start looking at what other people are doing. We've got to look at the people that we're looking at, blood clotting with fibrinogen or lipoprotein little a, which even in 1994, 30 years ago now, right? This is 2024, 30 years ago when I presented this, and I said lipoprotein little a is a factor. It's only today, it's only in the last 6 months that American Heart and the American College of Cardiology is coming out and going, you know what? I think this lipoprotein little a has something to do with it. Yeah, it does. Um,
Which you had me run, by the way, a few months ago.
yeah.
Wasn't good.
Homocysteine, the different lipid factors, trauma that we induce, when we go in and do cardiac cath or stentings or surgical traumas or anything else that does it, and infections, because that's when I brought out the infectious component. And I did research on, certain bacteria after that point in time that was, those studies came out in the early 2000s, looking at people and seeing the immune system activated and the thymus gland activated and treating these people and seeing heart disease get better with the treatment of these bacterial infections. So, all of this has taken a long time, it seems like it to me. But I had to take about 6 months of my life and say, I've got to take a serious look at what other people are talking about that I may not be as familiar with. And I need to look and I need to vet what's being said here. And that, in many instances, meant I was looking outside of cardiology. I was looking at other fields of medicine. I was looking at other countries. I was looking in the dietetic and nutrition field areas, and just categories that normally you wouldn't. But it was bothering me that it's like Einstein said, if you don't understand something, it's because you don't understand it. It can't be that complicated. And I realized that my diagram back there looks pretty complicated, and like it's a Where's Waldo graphic, I think. But
It's a good way to put it. I get lost in it, trying to understand
yeah,
it.
yeah, and I always teach my students, it's like, well, if you think it's hard to do that, you should have been the person putting it together. Because it wasn't a book to follow. It was just, drawing after drawing after drawing. And I shredded everything before this because I was just, frustrated and determined that, well, if it wasn't working that way, get rid of it. Don't hang on to it. Don't do an ego thing of saying, well, I spent all this time in this field, it's gonna have to be the dominant thing. It's no. If I want to do this right, you have to step back out of it long enough and say, what are the other people doing to contribute to this? And it may not all be equal, but they were all demonstrating something, so it had to fit together. And it took a while to put it together, and I can tell you that's not complete. I know where the gaps are, and we've been looking at that.
Okay.
I get some years where they get to look at more things, and then something like COVID will pop up and distract my attention and take me away from it for a while. But I'll get back to it.
Yeah, just the last 5 years. So I'm going to backtrack one quick question. So you talked about insults. So multiple insults. Are you referring to multiple like boosters? Like you've already got an insult, and then
Yeah,
you go
so
to get another booster, and then you get another booster, and I'm assuming that's what you mean, to clarify that?
well, you can have insults from a number of things. You could have multiple infections, right? You could have other infections that come into your body that tip off the inflammothrombotic response. Certainly, boosters are going to be another thing. I mean, there's very clear and concerning data on what happens to the immune system when people are getting repeat vaccinations. And I think that it raises a whole host of questions, at least to me, right? One of the things is that we want to see an immunoglobulin made, an antibody, right? And antibodies have drawbacks, by the way. There's just because you make antibodies is not always a good thing, as we know from strep throat and heart disease, rheumatic heart disease that occurs from it, as the easy example that everybody knows about. But just because you can make an antibody doesn't mean it's a good thing. But there are certain types of antibodies that have certain effects. And when you are making an antibody known as G, immunoglobulin G, we really want IgG3 to be made for infections. IgG4 is what happens when your body is saying, this is a part of me, I don't like it, and that's how autoimmune diseases occur. And what we're seeing in the studies that have been looking at this is that the more frequently people have been vaccinated for SARS-CoV-2 with these genetic vaccines, their antibodies are shifting from IgG3, the good guys, to IgG4, which has two effects. First off, three effects. It doesn't have the complement part, so it won't allow clotting to occur. So you're not going to wall off whatever the problem is, number one.
Okay.
Number two, IgG4 behaves more like an autoimmune disease. And so you start to see these autoimmune diseases. The other thing is that because IgG4 has an effect on cancers, it is one of the 9 pathways that allows cancers to flourish. So when IgG4 is present, cancers can use these, or some of them can, to hide from our immune system, allowing the cancer to go undetected and to grow. Is this due to the genetic vaccines? You know, this is the only place we have this data that I'm familiar with. Is it the frequency with which these vaccines are being given? You know, in other words, if your body is looking at something and you're repeatedly getting vaccinated from it, how will the immune system view that? Will it say, that's a part of me. I'm seeing it frequently enough, it looks like it's a part of me. So is it the rapidity, the frequency? Is it the fact that it's a genetic vaccine with pseudouridine that's impairing the interferon? Right? Is it, or is it the frequency? Would we see this? And I don't know the answer to this. Would we see this if we multiple vaccinated people with a lot of vaccines all at once? Or is it the fact that it's a lot of the repeated vaccines, which is probably what I suspect is going on? So, you know, it raises all sorts of questions about how frequently can you vaccinate a human being for something without causing this shift that produces problems? And again, just because you can make antibodies doesn't mean it's a good thing that you do, right? And you've all seen people that have gotten better after just a few days of being infected. That means their innate immune system kicked in, the INNATE, where the T cells get involved and they produce this inflammatory thrombotic response and they bring it under control, and you don't make an antibody response, or it's minuscule. And you know, all know people that have had, you know, they go out 2 weeks, well, they're making antibodies, right? Because at 7 to 10 days, that's when the antibodies, the adaptive humoral antibody system kicks in. So, and you see the consequences on these people. You know, many of these people that respond in a few days, they don't look worse for the wear, but other people that take longer, are they worse for the wear just simply because it dredged out that long? Was it because of the antibody response? I think these are good questions. They're not answered questions, and we're not going to get answers to those questions because I always think of this somewhat tongue-in-cheek. We don't experiment on human beings, do we? I have to think of that tongue-in-cheek these days because I would argue we do. But ethically, we don't, right? So it's
Right.
what do you have to do to make it look like you're not doing it, but you do that, right?
Okay, well, thank you for that answer. I'm going to bypass a few questions just because of time, but you know, I
Sure.
often refer to the shot as a toxin. And the reason that I do that is because the shots, the vaccines, even childhood vaccines, I mean, most of us have had child vaccines, they all contain adjuvants like aluminum, thimerosal, mercury, and other toxins in order to open up the cell to get in what they're injecting in you. So I guess for me, I can't believe that one, mainstream media, medical doesn't talk about this. Two, that the pharmacists aren't giving informed consent to say, hey, here's your shot, but did you know that these heavy metals are in here and aluminum or mercury for that part may have an ill effect on your brain. Could you comment on the adjuvants and maybe just give us a brief reason why pharmacists and doctors aren't even talking about this?
Well, yeah, again, there's going to be a spectrum of responses of why people aren't talking about it, all the way from they don't know anything about it to conflicts of interest, right? Where there's a benefit to them, and everything in between. I think by and large, and I think we touched on this last time, when you go to medical college or you're a medical student and you're trying to understand all this information, and you're trying to learn how to take care of patients, and you learn pharmacology, you know, these are the drugs to use for these diseases, and this is how they work. That's really kind of your function as a physician. You know, physicians aren't scientists. I mean, they're not research scientists, right?
Right.
And you hear me talk about this all the time. PhDs solve problems, MDs treat problems, JDs cause problems. Again, if you're a JD out there listening, I'm one of you guys, so it's okay. There's no point in arguing me on this one. So physicians are trying to learn, this is the problem, this is the drug. Implicit in that is the concept that if supposedly these drugs have to be approved, that there are people that are supposed to do the job to make certain that these things are safe, right? And if they don't do that, you know, that now you're asking physicians to take on the responsibility that they're not qualified to take on. They're, you know, being an MD does not train you in that. It trains you on recognize the problem, how to treat the problem. You are dependent upon other people to be doing their jobs, right? In addition to the books that you talked about that I've written, I have another one that's coming out called Are We the Next Endangered Species? Bioweapons, Eugenics, and More. And in that, I discuss the consequences of what has happened over the last 170 years, particularly in the United States, that has gotten us into the state of affairs that we currently are. And one of the problems, and I might as well just bring it up now because it's going to come out in the book, is the Vaccine Act that protects vaccine manufacturers. When you look at that, and in the book, there's some things that I will tell you that I won't tell you now that are important to understand to know how to deal with this Vaccine Act. Because
And that Vaccine Act goes back to Ronald Reagan in
Ronald Reagan,
1983.
Right. I think it's 83. I'd have to look at that one, but it was Ronald Reagan that signed it over. And the Supreme Court, the thing that I'll give you is kind of a carrot dangling here is that if you actually read what the Supreme Court said, you would not argue about it the way people are arguing about it. If you actually took what the Supreme Court said, and again, it's in the book, and I'm not going to take time to go into it now. When the book comes out, I'll be happy to talk to you again about that. You'll find out what the real flaw to the argument is. And in reality, there is a mechanism, and it's proposed in the book, for legislation to be passed to revoke the Vaccine Act. But it explains it in the way that it needs to be done legally. Because it's very easy, I think, to look at something and say, there's a problem. It is something else yet again to know how to take on that problem. And with most things, there's a good way and a way that's not so good. And when you consider that there are people whose livelihoods depend upon the money that comes from this, you should expect that they are going to fight tooth and nail to protect it. But the end result of this, and again, it's in the book, is this is the obligation for them to make products that are safe need to be established, and you don't get a break for making a product that may harm people. Again, reflect back to the swine flu vaccine in the 1970s. There were a total of 52 deaths, and it got pulled by the FDA. The whole process started after about 26 deaths, 22 to 26 deaths. But it was at 52 deaths. That's by that time they had it pulled. We're over 34,000 deaths with these vaccines. So either we're incredibly stupid compared to the people in the 1970s, or they were a lot more compassionate and caring about human beings than we are today, and a lot more centered about, society as a whole versus what we are today. And yet the narrative comes off the exact opposite, right? We're the intelligent group that really all care about everybody singing or sitting around singing Kumbaya.
All right, we just lost Dr. Fleming on Kumbaya. Oh, there he is. Hold on 1 second. Can't hear you. Not saying you're loco. I can't hear you. Okay, while Dr. Fleming is going to restart.
Can you hear me?
Oh, there you are.
Yeah.
Okay. I was just getting
yeah.
ready, to talk about your book and maybe go on and talk about the next question. Did you need to finish up with that before I move on to the next question?
No, I mean, I think you got most of the gist of that, and I'm not sure what was going on with the earpods, but they're fine.
You know what? I'll comment. I think that maybe they were a bit more compassionate and a little bit less greedy back then because they stopped. But I just honestly believe that as much money is being made right now and as many millionaires, billionaires that, I mean, listen, it's one of the 7 deadly sins is money. So I'm just going to put that out. That's my personal opinion on how I feel.
Yeah, well, let's remember also that the swine flu vaccine that was done was a standard vaccine. It was not a genetic modification vaccine. I think, it's my opinion, and I explain this in the book, that these were simultaneous programs, and the people, once this biological viral weapon, this virus, SARS-CoV-2, get out, all this did was provide an opportunity for the people that were doing genetic vaccine gene therapy research. All that did was give them an opportunity to accelerate what they were doing. And they're right when they talk about it. And they said, 5-10 years ago, if you'd asked people if they wanted to be involved in genetic research, a genetic vaccine, people would have said no. There's no data. But you put them under enough concern about a bad outcome, about dying or having a bad health consequence, and you start to see people stand up volunteering to be part of something that only a couple years before they would have flat out rejected. So it's very easy to change people's behavior if you put them in the right frame of mind.
Right. And I agree. I think being locked down, forcing that whole fear on majority of the people, loss of their jobs. I mean, I think that had something to do with it. But real quick, I just want to ask you a few things because solutions, for people to find further research. Last we talked about on our last podcast on cold and the virus. How long can COVID last on a surface? If somebody coughs or sneezes, and most people aren't wearing masks, but they're still traveling when they're sick. And I know that because I recently flew and it was totally disgusting. How long can it last on a hard surface? And then I want to ask a couple of vitamin C questions, and then we're going to move on to some of the things that I want to talk to you about in your Stop Inflammation Now book that are important.
Well, one of the aspects has to do with what type of surface that the virus actually lands on. And I knew there's been a lot of interest in that, whether it's a metal or a soft tissue or something like that. But SARS-CoV-2, the data that's been collected on it shows that, for example, if it were to land on a copper surface, it tends to survive for about 4 hours. If it lands on a cardboard surface, it tends to last for about a day. And if it lands on plastic or stainless steel, it can last up to 3 days.
So like an
And
airplane seat, pretty much.
so yes, where you've got that steel there, it certainly can. And I don't know if you've paid much attention to how poorly they clean airplanes, jets,
Oh,
but
not good.
it's not well. So this is true, and every virus has a different ability to sustain itself. But for SARS-CoV-2, these are the numbers that are showing up in the research repeatedly.
Okay, so let's just talk a minute or so on vitamin C. And the reason that I want to bring this up again is because, it cannot be made in the body. And the
Right.
RDA is behind. I mean, 75 milligrams, that was what people needed to prevent scurvy. So how do you feel about vitamin C, and what type of vitamin C is the best type? Because the rage seems all about liposomal, but we've talked about taking a vitamin C and then
Right.
encapsulating it in a fat lipid, which it's no longer a vitamin C, it's a fat lipid. So can you just spend a few minutes talking about that, please?
Well, to begin with, it's important to know that vitamin C actually has a couple different benefits. One is its antioxidant effect, which people talk about a lot. This is where oxygen itself, when you tear it apart, is highly reactive, and it can be highly toxic. It's highly beneficial if you're using it for the right reason. I mean, if you put hydrogen peroxide on something, you see that bubbling, that's the oxygen gas coming off, and there's free radicals, and it's a very good killing agent. It's just
Right?
that you don't want that killing agent inside your body, killing your cells and damaging your blood vessels. It interferes, free radicals or nitrous oxide, however you want to refer to it, interfere with the ability of the arteries to relax, to increase blood flow, which is critical, particularly for the heart. So that's one of the consequences. There's also the fact that vitamin C is important to help the innate, the T cells, and it's important to help the B cells, the adaptive humoral antibody part. So it plays a role on all of that. It's also very important as far as integrity of blood vessels, because you'll see people with little pink spots on their skin. These are the small blood vessels that are very fragile. And one of the things that can cause that is a vitamin C deficiency. So, most of the RDA information really is based upon a very small period of time that research was done looking that happened because people were using larger than appropriate doses of the fat soluble vitamins. So A, K, E, and D, right? So you're happy I used the word vitamin for you there instead of vitamin.
I think Leora and
These,
I are happy,
right. So
but I'm
occasionally
still saying
I'd throw
vitamin.
that in for you. That's
Thank you.
good. Um, so when these fat soluble vitamins are used, they build up in fatty tissue. So the brain, the eyes, the heart, the liver. So when people were taking excess amounts of these, they didn't know any better. You know, a little is good, a lot must be great, right? there were toxic consequences, and that kind of stirred up this entire thing. And they started looking at what the limitations should be on that. But there wasn't a lot of thought given to, well, all the water soluble vitamins, it's really hard to get too much, because what happens to the excess? It doesn't get stored in fat, it gets urinated out.
Right.
So a lot of data really didn't exist. And a lot of data didn't exist on the role of vitamins and minerals and nutrition and diet and exercise. It really didn't exist on the immune system. It's really only been of late that there's been some talk and discussion about this. I'd like to think that some of the work I did helped in that, but there's been a lot of people that have been involved in trying to say, wait a minute, let's look at this. Much of the conflicting early data on vitamin C had to do with the fact that there'd be this 72-hour benefit, which is about the amount of time that it took the kidneys to realize, wait a minute, there's more than usual. We're supposed to dump the extra, which raises the questions of, well, if you're dealing with something and you're getting a benefit and now you're losing the benefit, does this mean you have to up the dose of what you're using? In this case, vitamin C. Maybe that is and you need to do that and think through the sequence, get through the problem you're treating, and then rein back on what you're doing. And this really should, I would argue, be the focus that we do on just about everything. Just because we put you on a statin medication, for example, to help try to calm things down, I would then argue then we need to teach you how to get your lipids under control, your diet and your lifestyle, and then try to rein you off these drugs. We shouldn't be putting you on drugs and just leaving you on it and not saying, well, that's good. We've got a key that will fit in a lock. We're good. Go home, be happy. I see this all the time with people who have had stents or angioplasties who say, "Oh, I don't have heart disease. My doctor gave me a stent and I don't have heart disease." No, buddy, you have heart disease. You now have extra parts in your arteries because of this. How about doing something to reduce the inflammothrombotic response that's going on?
Right.
Our putting a stent in there didn't make that go away. In fact, it actually caused some damage to the artery, if you, in truth, that, it's now there.
Okay.
The,
Okay.
yeah.
So,
And you asked about different types of vitamin C. Again, there are basically two classes of vitamin C. There is ascorbic acid, which is an acid, right?
right.
Hence, ascorbic acid. And you have sodium ascorbate, which is a salt. And if you look at many of the vitamin C receptors on cells, they are very much more tuned to the salt, the sodium ascorbate, than they are to an acid, right? I mean, they're not expecting an acid to come into the body. Your body can deal with it. The question about how well it's going to be taken up is a different issue. You can fill the bloodstream up with it as high a number as you want. That doesn't mean it's getting inside the cells to have the effect. Odds
right.
are it will. The more you build up, the more is likely to get in, but it doesn't mean it will. And then, for that last point, if you have a fat soluble vitamin, wrap it in a fat soluble layer, like lipid nanoparticles. Knock it out because it's fat soluble, fat soluble. But if you have something that's water soluble, like vitamin C, you shouldn't be wrapping it in a fat layer because that's not, it's the wrong pathway. I don't know if I have to explain that in more detail.
That that makes sense. I mean, to me, it does make sense on that. So what's your feeling on nanokinase? And
So
just so before you answer that, just so I don't cut you off, we have a couple of callers waiting on some long haul
okay.
questions.
So
And I still have several questions I've got prepared.
right. So in other words, make it short. And that doesn't work with me, but I appreciate your attempt to make it work that way. So nattokinase is something, again, there isn't data to be compelling that this is a drug that you take. There are all sorts of health problems that people have talked about soy protein of one sort or another. I've done research with breast cancer using FMTVDM or Fleming method, measuring the effect. In some women, the soy protein made their breast health improve. In other women, it made it worse. Being able to measure that was significant because it allowed us to say, well, it may read well in the textbook, but for you, ma'am, it doesn't read well. So until you actually measure the effect of a treatment, you can speculate as much as you want, but we know the pharmaceutical industry can tell you this, quite frankly, that when they think they have a drug that works because people look like they're better, in reality, when they measure it, it's only working 10% of the time. Only 10% of the drugs work. 90% that they thought worked, the patients weren't getting better because of the drug. They were getting better because they were getting better. And that's one of the reasons why you have to measure things. So if you're going to propose that something be used for a reason, you should want to be able to demonstrate an actual effect, because if you're going to apply this do no harm philosophy, which by the way is not in the Hippocratic Oath, but if you want to apply this do no harm philosophy, you need to be consistent across the board. You can't look at big pharma and say you guys violate the rules and you're just interested in money, while at the same time you're not doing the work you need to do to prove it, and you're just saying, well, people tell me they're getting better, and I don't think it's harming them. Well, I hear that same thing from the genetic vaccine manufacturers. People tell us they're getting better, and okay. So without objective data that would compel you to say, I would do this for my husband, my wife, my son, my daughter, the people I love, unless you're wanting to turn them into guinea pigs, which we've done really a good job at in the last few years of turning everybody into a guinea pig. No offense to guinea pigs. You need to get your act and your data together before you decide to promote something.
Okay, yeah, I definitely agree. I mean, it's, before I go on to the next question on LDL and triglycerides, I just kind of wanted to say something. I personally need to vent about everything that's going on. So, I mean, just in this whole disease world, the allostatic load in our bodies, what's driving up inflammation and disease. But, there's been decades of researching on toxins and the harmful effects that it does to the body, the dangers of herbicides and Roundup. And after reading your book on Stop Inflammation Now, which honestly, my opinion, I believe should be in the hands of every medical doctor, as well as anyone wanting to learn about a healthy eating lifestyle without saturated fats, so that these doctors can educate their patients, because I'm not hearing it. It's like, I many friends that are, hey, put you on a statin, but they don't talk about CoQ10. So, it goes to the farmers that are spraying these deadly chemicals like Roundup and glufosinate and Liberty and all of these HOAs, all these new communities going on, hundreds of other chemicals on the farming crops that they're growing, which is now turned the once nutrient dense soil to crappy dirt that has removed nutrients that our body needs and amino acids that our bodies can't even make. The links to disease and cancer due to consumers eating these poisons and doctors not looking at root cause, and not all doctors, by the way. The lack of being able to find the truth, which is why I'm thankful about Main Street Media Utah for allowing us to speak the truth. It gives us a voice. But I have to tell you, I am disgusted with big government, big ag, big EPA, that they are allowing this to happen to the American people. And I'm sickened by big pharma, thinking that they have a cure for disease when in fact, big pharma keeps the American people as well as the rest of the world in sick care, a sick care system to sell them more drugs, having them come back for more drugs, more doctor appointments, just because they're failing to talk about root cause. How about talking about amino acids? How about talking about the diet? How about talking about the stuff that you are talking about in the book? Saturated fats. You know, people that consume a lot of liquor, people that consume a lot of sugar, which by the way is sprayed with poison. So I just wanted to get that out there because I'm not seeing it enough. So with that said, thank you for allowing me to vent, by the way. I'm going to ask the next question. And this comes from your book again, Stop Inflammation Now, which again, if there is any medical doctor out there listening, if you send me an email at info@wellnesscrusaders.com, I will gladly ship you one of Dr. Richard Fleming's book, courtesy of the Wellness Crusaders. So high blood pressure, high LDL, high triglycerides, high C-reactive protein markers, high homocysteine. Most people don't even know what homocysteine is, let alone C-reactive protein. Most people barely understand what those last two are. So let's talk about that. How does LDL and high triglycerides burden our health?
So when people talk about cholesterol and fats, they frequently don't understand that you can't separate those out. Maybe that's a storyline for the night. You can't separate electro from magnetism, you can't separate inflammo from thrombotic, and you can't separate saturated fats from cholesterol. When we look at the cholesterol molecules, we refer to them based upon what's more prominent. Is it more of the saturated fat? Is it more of the cholesterol? If we put it in a centrifuge and spin it around, where we'll layer out, that's how we get the terms high density, intermediate, low density, very low density, and chylomicrons. We know that the addition of these saturated fats, and this is exactly identical to the fat soluble vitamins A, K, E, and D. Some is good, too much produces a problem, and they get deposited in fatty tissue. One of those
Right.
tissues is the heart, and the heart likes to have fat floating around near it because you can get 9 calories per gram from fat, 4 calories per gram roughly from protein or carbohydrate, 7 calories per gram from alcohol. So the heart tends to like to have some of that fat floating around in case of an emergency. But that doesn't mean you're supposed to stuff the arteries with that fat for an emergency. That doesn't happen because we're not living on the Serengeti running from lions and tigers and bears. Most of us are relatively comfortable in our homes, take a vehicle to work. Most people don't even walk up the flight of stairs, for crying out loud. They take the lift, the elevator to get up and down. So there's not ebbing up and down. And what's happened over the course of time is these fats will be put in the arteries, and our immune system, our monocytes and our macrophages go in and they find things that shouldn't be there. They eat them, and then they try to get out of there with them. But what has happened in the American diet and lifestyle, and by the way, let's put this out there. You get the same problem by eating too much refined sugar. All right. You don't have to be a rocket scientist here. Excess calories get turned into fat. And it doesn't matter whether it started as fat or it started as something else. You eat more calories than you need. Refined processed sugars are easy to put a lot of calories in a small space and eat a lot of calories. Too much, you make fat out of it. We used to be able to ask second graders that and they could answer that, but adults would do all sorts of mental gymnastics to justify this. So we get into this battle, which shouldn't even exist because both have problems. The monocytes get in there, they engulf the stuff, they try to get rid of it. They have to get into the walls of the arteries, which are the major part of the arteries that are significant, because that's the part that allows them to relax to increase their blood flow. When they get filled up with material and you try to get that out, those white blood cells of your immune system that are going in to attack something that shouldn't be there can't get back out because they're so stuffed they can't fit through the pores, the openings, the senesqua fenestrations to get out, and they get trapped and then they die. And when cells die, it doesn't matter whether it's your immune cells or a cancer cell or anything else, what you see is calcium show up because the calcium leaks out and then it has no place to go. And then you get other monocytes that come in and they try and clean up the garbage and they get trapped and they die. And before you know it, you've got this calcium, you've got this inflammation and blood clotting going on inside the wall of the blood vessel. It can't dilate to carry more blood flow. And you have heart disease, and the same thing happens in the brain. You get, quote, strokes, the cerebrovascular accidents, and you get these bad consequences. So all of this plays a role. And that's why the theory in 94 was, let's look objectively at what the people that are spending decades of their life are trying to tell us, and let's put it together in a model that explains. And in some ways, it's like a spider's web. Nobody has the same effect, just like nobody has the same effect from the virus being presented at them. Two people in the same room, different states of health are going to have a different response to the same amount of virus being coughed onto them. So one person is going to respond more critically to the fats. One person's going to respond more to clotting factor fibrinogen, some to lipoprotein low A, some to homocysteine, some to a bacterial infection, some to a viral infection, some to any of a number of other traumas that are going on in the body. You fall down, you cut your knee, it causes an inflammatory thrombotic response. Well, that doesn't just happen there at the knee. Those chemicals are being released in that area. So different effects for different people. And the process of looking at that objectively, instead of saying, just give me a single thing, just tell me what the one thing is that I have to work on. Well, your health. You're doing a whole bunch of things to make it very hard for your body to have its maximum health. You've gotten overweight. You've increased the fats, you've increased the sugars, you're drinking too much, you're not exercising enough. Let's see, did I see that happen? Yeah, during the pandemic, when we all locked down, what happened? People ate garbage, they didn't exercise, they drank alcohol, they smoked like a chimney, right? The old that causes your blood vessels to shrink down and blood to clot. I mean, if you want to have a heart attack or a stroke, it's a semi-free society, but there are consequences. And what most people don't fully appreciate until it happens is that you don't usually get to die. You
Right,
get damage and you
right.
have to live with that damage, and then it causes more challenges to you and it makes it harder for you to recover, and then there's more damage and you start this bad cycle. And I'm not a believer that just because you start that bad cycle you can't spin it backwards, because I've worked with a lot of people and spun it backwards, but in the end it's not me telling them, it's them doing.
Okay. And I agree with that after reading your book, but even before then. So we only have a few minutes left, and then we've got to open it up to Q&A. So I'm going to ask a few questions, and then maybe hopefully your answer could just be a tad shorter, because I want to make sure we get at least 15 minutes worth of questions. So with the people who, and then we just lost his camera. So there's a couple more questions. There's a couple more questions I want to ask. I'm going to kind of ask them, and then maybe you can, we've got like 5 minutes. So, and this is related to the people who got the COVID shot. Because I'm curious if these medical doctors are looking for this, since we just see so much, pericarditis, myocarditis, heart inflammation, inflammothrombotic disease. So in the people who have the shot, should they be aware on small cholesterol plaques versus large cholesterol plaques, and which one is worse, large or small?
Well, obviously, the larger the plaque, the more burden there is, the more likely you're going to have a problem. I think maybe what you're referring to is the difference between stable and unstable plaques. And the difference between those two is that stable plaques tend to have more scarring, fibrosis, and calcium deposition. They're rigid, they don't tend to rupture as easily. The unstable ones are the ones that are lipid laden, the cholesterol and the fats. And it's interesting, when you look into an artery, there's a special device called an angioscope. You can actually look in the artery. You've seen slides of this in some of my presentations, but you may not have known you were looking at that, where the stable ones have this grayish white appearance, which is what a scar looks like, and the yellow ones have this. These are the lipid laden ones, the unstable ones, and they have a tendency, like a pimple, if you will, to rupture, and your blood vessel interprets the rupture, the loss of integrity of its wall. It doesn't know that it's not going outside. It just knows the wall has been ruptured. It recognizes that as a problem, and it causes an inflammothrombotic response. The most significant part of which you tend to notice is the blood clot. And so when that blood clot occurs to try to clamp off the injury, those blood clots tend to increase in size, and if they get big enough, they will block the area where the blood is flowing, depriving everything downstream of getting blood. And so when you have that in your heart, you have a myocardial heart infarction, tissue damage, what a lot of people generally refer to as heart attack, although, again, as I've said, they're slightly different. If you have that in the brain, you have a cerebrovascular accident, or what a lot of people refer to as a stroke. And I've talked about that, that comes from because you must have done something wrong, so God struck you down. So that's why I don't like that term. And any place else that you do that, you can lose or have injury, like blood clots to the legs. Gangrene causes this blood clotting, and you lose extremities from this same type of phenomenon. Right?
Okay. All right. I have one last question, and then I want to read a blurb out of your book.
Okay.
That's really
Okay.
important. So, what's happening right now with what we are seeing and what we are hearing with all these people having like thick blood? I mean, it's kind of crazy what we're seeing and hearing.
Right. So part of, that tends to be, there's a couple of reasons for why that can happen. I mean, you can have increases in fibrinogen and clotting factor, which can do that. But I will tell you that one of the things that Dr. McCarran and I did was to look at the consequences of adding these genetic vaccines to human blood directly and watching what happened to blood. And two very striking things occurred. First off, red blood turned gray, which means there was a cryogenic effect on the hemoglobin of the red blood cells.
Right.
And the second thing that happened was the blood tends to clot. So all of these questions about, autopsies and morticians pulling these discolored clots out of people, guess what? That's exactly what we showed, but we showed it real time under the microscope so you could see it. And then we have published this paper. So when other drugs were added that are normally found in the blood, it didn't do that. So it's not a factor of adding something to the blood. It wasn't a time factor because we watched these other samples with these other drugs added for the same amount of time. In fact, the clotting and the discoloration occurred in 15 to 20 seconds. So that's a lot faster than you would expect to see it. It's very clear that there's some immediate effect. Does your blood turn over and constantly make itself? Yes. Should there be a lot in your blood? No. But the point is, it shouldn't happen at all. And we know that these injections don't stay at the site of injection. In fact, if they did, they couldn't work because they have to get out of the area to your lymph nodes for your immune system to develop a response. And we also know back from the 2015 era when Moderna published its influenza lipid nanoparticle mRNA vaccine, that the vaccine and the lipid nanoparticles were found all over the body. So for anybody after 2015 to say we didn't expect this to go around the body is either disingenuous or ill-informed. And if they're ill-informed but in the field and not aware of a major paper like that that was published on their topic, they're not much of a scientist or physician. They probably should just get out of the field and do everybody the benefit.
And I agree with you because I think so many people were ill-informed, tricked, feared into doing what they had to do. But I want to finish this up by reading a short sentence from your book, Stop Inflammation Now, which I thought was one of the better books that I've read in order to really understand what's going on with inflammatory thrombotic disease. And I'm seeing this now, which is why it's important for me to read. You have in this book, we weren't working together, and no one wanted to credit their colleagues with anything. So researchers weren't working with the cholesterol. They ignored the work on homocysteine, and the homocysteine people ignored the work on fibrinogen. The fight to determine who was right took precedence over finding the truth. So I unfortunately still see this happening. There are a lot of really great doctors, and I have a lot of really good doctor friends, and they're fighting the good battle. But we're not seeing as much collaboration as some of us would have hoped for. So Dr. Fleming, you're brilliant in my mind. I mean, I've read a lot of your books. I've researched a lot of your studies. You've researched and published so much data on heart disease in SARS-CoV-2. You're, again, one of the most brilliant doctors I know. Why should these doctors be using your research, and what would you like to tell the doctors who aren't using you to follow you? And then we'll go to Q&A.
Well, I think the major reason for using the research is consistent, not just for myself, but why you look at research that's been done over the decades before you. You build upon the research of the people before you. One of the things that I've always insisted on in the research papers I've published is the crediting of other people. When I did my first nuclear isotope paper on something called tebaroxime, when I was a cardiology fellow, I insisted that the nurses and the technologists in the lab that were critical to getting the work done be on the research paper. And the other cardiologists did not want that to happen. And I said, well, that's just kind of too bad because I'm writing it and they're going to be on it. And they were just stunned and overly appreciative of the fact that their names were put on there for the work that they did. Part of the function of looking at research that's been done is to learn from the people that have done the work before us. You know, the work that I've done is built upon work that people before me did, and I'm forever indebted to them. Had they not done that work, I would be back there doing that type of work. But the work that I've done hasn't been focused on anything but trying to get to the answers to help do a better job of figuring out what the problems are and to address treatments. And it's fundamental for all of us to try to take a very objective approach and do what I teach my students, which is we may disagree on some of what we talk about. But at the end of the day, if you can look other people in the eye and say, this is what I would have done for my husband, my wife, my sister, my brother, my mother, my father, my children, then you're probably doing the right thing for the right reason. If you're doing it for some other reason, if you're getting compensation for it, and that's what's driving you, there's potential conflict of interest. If you're, there's a variety of problems. The important thing to remember is that our focus is about our patients and about the people who trained us. That's what our Hippocratic and Geneva oaths say that we will focus on. And to be legitimate, that's what you need to focus on. This information I published for the express purpose of having it out there for other people to be aware of it. When people won't look at the research that others have done, they are trying to reinvent the wheel. That puts them at a real disadvantage, and it puts their patients at a real disadvantage. There's not a single thing that I've done in my life that is the end point of what I've done. As I said, that diagram back there may look like Where's Waldo, but I'm still looking for Where's Waldo and the missing pieces. They don't have to redo that. They don't have to develop techniques to measure tissue changes. This is available for people to use. It is also important that we bring our expertise together. Much of what's on that diagram back there, I didn't originally know about until I went to look at other people, stepped outside of my, I guess if we need to put it this way, out of my ego, and say, what can I learn from these people? What are they trying to teach me? What is their science trying to teach me? And when I did that and incorporated that, this is what I got. The theory that is now the theory that's accepted for what causes heart disease and these other chronic inflammatory diseases. I wouldn't be able to do that had I not stepped back and said, what are these other people that have done this work trying to teach me? My offering is what I have to teach and to help the patients and for us to build upon.
Thank you for that. And so if there's any medical doctors out there listening, I mean, honestly, there's some big names out there. I'm hoping and praying that this is the year that all of you come together because it's the work that you've done in inflammothrombotic. It's the work that Dr. Pierre Corey is doing and some of the other doctors that are doing some really good things. But it's time to all get on the bandwagon, have one big conference call. I saw you at the Senate with Dr. Malone, and both of you guys worked together really well. And I really appreciated that. But what we're going to do now is I'm going to put up the book cover, but in the meantime, I want you to let the listeners know, and mostly really any medical doctors that are really looking for answers. How can they find you and your work? Where should they go? Is it 10letters.org? Is it your other website? Please talk about both. And then Leighton has a question that one of the callers left, so we'll finish off with that.
Okay, excellent. So it depends upon what you're looking for. On FlemingMethod.com, that is focused on explaining this inflammothrombotic response, the measurement of it with FMTVDM or Fleming methods, so that you can find out what's happening to a patient. You can provide treatments to patients, and then you can measure whether that treatment works, so that we're actually tailoring for the patient. You know, like very much like that example I did with the different ladies with soy protein and their effects on breast cancer and breast health. Some get better, some get worse. The way to really know is to measure that at the tissue level. There's a lot of information on there about SARS-CoV-2 and COVID and all the rest. Hello, Lindsay. There is information on 10letters.org to help people understand how to get the information to their attorney generals and their governors to call for accountability. The book with Skyhorse Publishing, Are We the Next Endangered Species? Bioweapons, Eugenics, and More, is going to lay out 170 years worth of American history, explaining exactly how we got here, how the laws happen, who gave ground to who and for what reason, how these biological viral weapons and some of the bacterial weapons got developed, how the gain of function got developed, how the biogenetics and the role of eugenics, the role of German Nazi scientists that were brought in the United States with MK Ultra and Operation Paperclip. It's going to be, in some ways, an uncomfortable but a very rewarding read for people to understand what really happened. And within that book, not only are there questions provided and answers and new questions raised, but there's information about what you can do to make a difference, whether it's the 10letters.org approach and going after the criminals responsible, whether it's changing legislation, because you'll read in there about my involvement with the Obama-Biden administration and the role that I was asked to play and the data that I collected and provided back that was primarily ignored, and what the general population wanted. So all of that's up and coming. FlemingMethod.com for just general information, 10letters.org for information on how you can approach this. And then the new book is going to very much directly look at that and the military industrial complex, because independent upon what party you tend to vote for, the only thing that's happened in the United States of America that has been bipartisan is the support of the military industrial complex. And we're living with the ramifications of it.
Okay, we look forward to that next book. Dr. Fleming, we do have a caller. Leighton, would you like to bring in that caller?
Yep, let me pull them right on in. Diana, you are live with the Wellness Crusaders. What question do you have for them today?
Is this with the Dr. Fleming?
That is, you're on live with Dr. Fleming and Laurie Gagan.
Yes, okay. I have severe PAD after I had 2 Pfizer shots, and I'm trying to see if there's a way to image to tell the difference, if it could be this fibrinogen versus plaque. Is there any way to know that?
So there is, and when you say PAD, that to me that means peripheral artery disease.
Yes.
Okay, and is this in your legs or in your hands?
In my legs, very, very.
And do you have diabetes?
No.
No. Okay. So the first thing, there are ways to image to see what the blood flow is. One of the easy ways to do that right now, there's a couple ways. One is called an ankle brachial index, and that's where you measure the blood pressure in the arms and in the ankles, and you compare that. I'm trusting they've done that because they've told you have peripheral artery disease. If you want to look at the blood,
I've done a CTA.
Okay, and they found calcium there.
Well,
okay.
They're just saying blockage, severe blockage. So I'm just concerned because I didn't have any of this until I had the vaccines.
Right. So you're wondering whether it's just so one thing you can do is you can get a fibrinogen blood test to see what the fibrinogen is. If you're actually looking to see if in the blood vessel itself it's due to the effect of the vaccine, the only way to really do that would be to take a biopsy of that and then to do what's known as histochemistry staining to look to see what they find.
Okay, it's in the arm.
Okay. Right. So and probably I would not suggest doing that type of thing because there are risks with it, including potential bleeding and blood clotting that could make that worse. So for you, I think the real question is whether it's impairing your ability to walk or to move around, and whether there's discoloration in your feet. And I don't want you to answer that question because I don't want you to expose that. I want you to just simply have that as your answer in your mind. Okay. One of the classic ways that has things that have been done to improve blood flow in peripheral artery disease is simply exercise. And that what happens when
I
you
do.
exercise? What happens when you exercise is exercise itself will bring down fibrinogen, one of the benefits. The
Oh,
other thing it does is it allows you to improve the blood flow to get through there. And in a blood vessel where there is disease, you have a tendency to develop blood vessels around that area. You have your own bypass. We have names for it: collateralization, neovascularization. All of those terms are used to mean the same thing. But if you have the use of the limb and you're utilizing it to improve your blood flow and decrease the fibrinogen, you will tend to form these collateral or additional blood vessels to bypass the area that is not working as well. As long as you can do that, and I don't know if you're limited by pain. Pain is one threshold. Claudication is the term for the pain that occurs when you exercise and then people are told to stop exercising. What you want to try to do with that, if you can do it, is to exercise and keep track of how much time you can exercise and push that and see if you can increase that limit, because what that means is that you are improving the blood flow around it as a result of doing it. The best way to monitor your overall blood flow non-invasively and inexpensively is with something known as ultrasound, and they can do Doppler flow studies, a CT the coronary calcium study for angiography tells you if there's calcium, but it doesn't tell you much else. And so the ultrasound
I'm sorry, that this was a CAT scan.
Right,
with
CT,
contrast.
right, CT angiogram, right.
I've got total blockage.
Right. Well, and are your feet discolored at all?
My right one is on the bottom. It's red most of the time. It's extremely painful, debilitating.
Right.
So.
The same things apply. Just what I've talked about there is the ability to do that, and the ability to. It's also important, particularly where it's at, is to make sure that your extremities are warm. Because if they're cooled down, your body tries not to lose heat and they will constrict those blood vessels, decreasing the blood flow, increasing clotting tendency. So you want to make sure that you keep those areas warm. You want to make sure they're dry. And you want to make sure that you're not putting undue pressure on something that can put pressure on a blood vessel and try to shut it off. So those are the best things to do for that. And then the other caveat that I would throw in there is all the different things that go into peripheral artery disease, the diet, the lifestyle. That's part of what that's a big part of what causes that. Can also cause disease elsewhere. And by watching your diet, getting the fats down, getting the extra calories down, watching what you're eating and exercising can go a long way to helping to pull the material, the inflammation, the cholesterol, and everything else, and the fats and the excess calories out of those blood vessels to give them an opportunity to heal up and to improve their blood flow. Ultrasound is a great way to just monitor that and check your progress.
And so to the caller as well, can I just say that if you're looking for some health coaching, you can send us an email at info@wellnesscrusaders.com, and we can help you in some dietary lifestyle changes on that. I personally have read Dr. Fleming's book, Stop Inflammation Now, on I would definitely say that is one of the books that you should buy because he lays out on that book the different, like phase 1 and phase 2. But we would be also happy, one of the holistic health coaches would be very happy to work with you. So info@thewellnesscrusaders.com, and just send us an email. And thank you for your call in. And then Dr. Fleming, we have Leighton is going to ask a call. We had a a caller that had called in and was sitting, and she had to go, but left Leighton her question.
Of course.
So Leighton?
All right. So we had a caller, but they couldn't stay on the line. They have a question about long hauler syndrome and what positive markers should they look for in blood tests, or when they get a blood test, what positive markers they should be looking for.
Okay, thank you, Leighton. So one of the questions I always have for people is, what are the symptoms that you're experiencing when you say long hauler? This is, that term for there's something happening in your body that you believe is due to the virus or the genetic vaccines, and the question always becomes, what part of your body are you having the problem with? Is it the brain? Is it concerns about prion disease? Is it the heart? Are you having questions about the rhythm of the heart or the strength of the heart? Is it your pancreas? Is it, insulin? Are you worried about something else? So the first question always is, and sadly, I know you're not online right now, is what part of your body, what organ system is the question concerning? It's from that you can say, okay, what are the types of tests that we need to do to look at that to sort out the details? So that's where you begin with that. Long hauler is that big term for all these different things that can happen, but different people are noticing different things. So that determines what type of testing you get, what type of blood work you get, and how you approach it.
So Dr. Fleming, I could probably shed a little light on that.
Okay.
Because she had called in earlier. So I think it's the inflammation where it actually probably in the central nervous system, it's going from like one hand, let's say a finger, and I'll just say maybe gout-like type symptoms. This person doesn't have the shot. It can transfer from one hand to one hand or one foot. It just seemed, and it was the alpha variant of this.
I lost you.
So I would say it's just the inflammation going around in the body, which then, tends to lead me to believe it's in the central nervous system. So I think that's
Right.
maybe what she had questions on.
Right, and if it's moving from one body part to the other, it as far as localizing it in the brain, that's probably not going to happen, because if it's moving, like if it's affecting the brain and it's large enough to see on an imaging study, it's not going to move from area to area of the body. So the question is there a marker for a generalized inflammation going on? So for SARS-CoV-2 or COVID, there's a couple specific ones. One of them is interleukin-6, typically abbreviated IL-6. This is one of the inflammatory markers that's elevated with SARS-CoV-2. Another quick and dirty test that I always tell people is not very helpful, but is also extremely helpful, is something known as erythrocyte sedimentation rate, sometimes referred to as a SED rate or an ESR. And the reason why this test is important is that if you have inflammation that's significant, or if you have an infection, or if you have a cancer, this will go up. So it's beneficial if it's not elevated. If it's elevated, it won't tell you why, but it says, okay, here are the things to go look for, right? Depending upon how high it is, you can separate things out to general inflammation, an infectious process, or even cancer. And there's only, there's only a small group of people in which this test is useless, and that's people with sickle cell anemia, because they cannot have an elevated sedimentation rate. And so if theirs is elevated, it's a false test. But it's a quick and dirty test, because if it's in the normal range, it's excluded a lot of problems. But interleukin-6 is a good one. CRP, C-reactive protein, is also a general test. It doesn't tell you where, but it tells you if there's an inflammation going on in the body. And then when you talk to me about something in your hands and feet and painful, I think of a neuropathy. And in that case, I think of a polyradicular neuropathy. In other words, many radicals or expressions of nerves coming off, neuropathy, impaired nerve. And so when I think of that, I actually think of things like a B12 deficiency, a vitamin B12 deficiency. And one of the interesting things about that is you can draw a B12 level if you want to. Certainly, that's going to be your ultimate thing, but you can also get a complete blood count, a CBC, with a differential. And if you are truly deficient in vitamin B12, you will have an anemia, fewer red blood cells than you should have, and the size of those red blood cells will be bigger than normal. So it will be a macrocytic, a large red blood cell, hyperchromic, more in the red blood cell because you have fewer of them. So it'll be a macrocytic hyperchromic anemia. And that is one of the markers of a B12 deficiency. And what patients with this deficiency have are these nerve, what we refer to as paresthesias, tingling sensations or painful sensations throughout the body, particularly at the the extremes of your arms or your legs. That's one thing. Another thing that will do that is blood flow, but that's typically seen with diabetes. So those would be the first things to consider.
Okay. Well, I think that's great. And then I didn't know if she had any other things, but I know it's getting late for you there. I know we have other callers on the line, but it's already 7:08 your time. So Dr. Fleming, I just want to say from the bottom of my heart, thank you. And I hope and pray that if there are any medical doctors out there, either listening on your Rumble, my Rumble, your Twitter, MainStreetMediaUtah.com, let's get together. We need to come together as a team. We're almost 5 years into it. People are still dying. And they're dying because they're not coming together. There's so much great information out there. And I would just be sad to see 2024 go by and to be in the same position that we are in 2025. Lives matter. Every single life matters. And it's up to each and every one of you medical doctors. So go to 10letters.org, go to theflemingmethod.com, buy Dr. Fleming's book, Stop Inflammation Now. If you are really, truly serious about getting your health and getting your heart under control, for the people who had COVID and had the spike protein, or for the people who have got the shots, take a look at his book, Stop Inflammation Now. And for the medical doctors out there, is COVID-19 a bioweapon? If you want a quick, down, dirty book that's going to give you the information, where it's going to lay out all the patents on where these patents, how many decades ago they started, this book and this book with all my notes. These are the two books. So I challenge the medical doctors out there, send me an email, info@thewellnesscrusaders.com, and I will send you the book. Dr. Fleming, from the bottom of my heart, thank you graciously for giving so much of your time. And you have a wonderful night, sir.
Thank you. Thank you for the invitation. Keep up the good work. It's helpful, I think, to people to get this type of information.
And thank you to Main Street Media Utah. They allow us to speak the truth and give the facts. And for now, good night.